Okay, so welcome everybody. Nikki Sainor here from the Health and Wellbeing team at Public Health England South East. Today we have a number of local authorities joining us to talking about using NHS Health Check, health equity audits for NHS Health Checks, and about how you can use HEAs to make universal programmes work for you effectively locally. Main speaker we'll be introducing shortly is Alan Orchard from Lancashire County Council, who's done a great job undertaking an HEA in line with the guidance so that it goes beyond equity of access to looking at outcomes as well, which is brilliant, and we look forward to hearing about that. We've also got short kind of snapshots from Stephen in Oxfordshire, Tom in Kent, and also slides prepared by Fatima in Hampshire, who I will be presenting on behalf of. The session will begin with the presentations, and there'll be Q&A, question and answers for everybody, Skype and or on phone. After that. So let's get started. So Ellen, if we could move on to the next slide. So what is an HEA and why bother? It's an excellent way to help you tailor a universal programme so it works locally. I feel sometimes people think, well, health equity audits are a bit of a luxury that you might not have time for, but actually that's exactly when they can really help, because they can provide robust data to inform decisions about resource allocation when budgets are tight. And through doing an HEA, getting that robust data, you can then work with your key stakeholders to tailor approaches to implementing the programme, making the most of the flexibilities within universal programmes so that the way that you implement actually suits the local population, but also supports the achievement of local system priorities. So, for example, if your integrated care system is looking to reduce unwarranted clinical variation in estimated and recorded disease prevalence, then something like health checks, which is going to identify all those people with hypertension AF, can really help. So it's about positioning it and pitching it in that way. So moving on to the next slide, let's have a quick look at the HEA cycle, which will be really familiar to some people, less so to others. Effectively, it's a review process that can help you understand how access to and outcomes from services are distributed in relation to the health needs of different groups. So are the resources and opportunities and access fairly distributed in relation to need? And if they're not, what can you do about that in order to maximise the impact of the programme and reduce health inequalities? And it can, of course, help with ensuring you're meeting equalities legislation requirements. It's worth noting that although the National Data Extract, which began late last year, is brilliant and can really help throw some light on equity issues, it's not a substitute for an HEA because it just simply doesn't have the breadth and depth of data there and a health equity audit can have. So, moving on to the next slide, proportionate universalism. Interesting, good times to be talking about this, what with it being 10 years on from the Marmot report. Marmot kind of told us 10 years ago, focusing solely on the most disadvantaged will not reduce health inequalities sufficiently, and that actions must be universal but applied with a scale and intensity that's proportionate to the level of disadvantage. And that is absolutely something that we advocate and promote and support in Public Health England, and it's in the best practice guidance for NHS health checks, specifically this year, about using those flexibilities to make sure you're addressing health inequalities and any inequity. And that's because we know, for example, if you want to engage people who are more at high risk from CVD, it often takes more time, effort and resource, not only to get them through the doors, but also to help them make and sustain behaviour change, comply with medication and so on. So how can health equity audits help you make the most of those flexibilities within universal programmes? If we move on to the next slide, people often say, and it's been said a number of times in the South East, universal programmes don't suit our population, NHS health checks attract the worried well, universal isn't affordable. Well, if you do exactly the same to everybody, you may well find that you increase health inequalities. After all, we've known about the inverse care law for nearly 50 years. I think it was 1971 where that phrase was coined, which recognises that those who most need services are the ones that often are least likely to access them. So I guess a key message from the webinar is don't do exactly the same to everyone. If you you can use your HEA to make the most of the flexibilities within a universal programme so that we're getting the right people through the doors to maximise health impact and address health inequalities. And again, as I mentioned, thinking about and mapping the programme to fit with achieving the local system priorities. And that could be a whole range of things, some of which we'll hear about shortly, whether it's risk-tailored letters, outreach, phone calls to people who don't turn up, working through the voluntary sector to prime so that people are more likely to respond to invites. Let's just have a quick look at the HEA guidance itself. It was developed and piloted, if we move on to the next slide, Eleanor, number 6. In the southeast, we piloted in Kent, Brighton, and Surrey. It takes a whole system approach. And what we mean by that, not a whole system approach, a whole pathway approach, but meaning that it's not just about looking at equity of access. What we really want people to do is look at the equity of the outcomes as well, which are critical. Now that's the gold standard, but we also, a key element of the guidance is about pragmatism, and scoping is crucial because you need to be pragmatic and cut your cloth according to the resources. The resources and time that's available, and doing something that's possible and practical is going to be better than doing nothing at all. So we've got our gold standard, but if you can't do that, do something. And at the same time, be ambitious. So design your ideal audit, what you would like to be able to do. If in practice you can't do that because you don't have access to the data to enable you to do it, then that's a perfectly legitimate recommendation of your HEAs to improve data management and extraction, so that you can do better HEAs, fuller HEAs in the future. Two other small points which are important. One is around senior buy-in. When you're doing an HEA, if you can get your Director of Public Health to be the sponsor, but also say engage your key NHS partners, CCG, ICS clinical leads. If you don't do that, the likelihood is you may well not have the leverage to take action on the inequity that you identify. And then another point, and I have my colleague Mel Earlham, who works in Yorkshire and Humber, my equivalent up there, we both felt when we were developing this that even if you don't have time for health equity audit, do look at the guidance, particularly the appendix, because it's a great standalone resource structured around the pathway stages that provides lots of tips, resources, examples that can be used to help you address inequity and to improve take-up. So let's now hear about how it works in practice. So I'm going to hand over to Alan Orchard from Lancashire to tell us about his experience of undertaking HEA in Lancashire.
Okay, thanks, Nikki. It's Alan Orchard here from Lancashire County Council. I lead Commissioner for Health Checks across the county. You should have in front of you a snapshot of Lancashire, looking at indices of deprivation, just a bit of background really. So it's a contrasting county, 12 district authorities, 2 unitary authorities. Areas of affluence such as Clitheroe, Lytham, parts of Lancaster and Garstang. Areas of high MD such as those quoted on the sheet in front of you, Morecambe, Fleetwood, Preston, and the East Lancashire districts, the old mill towns of Burnley and Accrington. In the middle of the county, we've got a large area of outstanding natural beauty, the Forest of Bowland, which is a lovely area, which we're all very proud of, but it's so reasonable size. Next slide, please. So, more background. Population of 1.2 million. We generally do well on the key measures that PHE ask us to measure. First of all, invitations, 100%. Secondly, health checks completed last 5 years, around about 70%. So we're in the right ballpark. The makeup of the county, however, with 6 CCGs and lots of surgeries and pharmacies is quite complicated. For example, the North CCG, only 4 practices following a lot of mergers. East Lancashire, the opposite, there's 80 practices, a lot of small single-handed practices. A lot of merging going on around the county as well as practices, and it tends to happen at year end. Next slide, please. I'll skate across the next 2 slides quickly because it's just showing our performance last 5 years, which is kind of stating what I already stated, that we're quite happy with where we're at in terms of numbers. So moving on to the slide titled Lancashire Delivery Model. 6 years ago, we were probably in a bad place. We were only delivering through GP surgeries, and performance was around about 5 or 10%, something like that. Very, very poor. We had a budget that wasn't being spent, so we decommissioned a third of that budget and set up 2 new tenders. We set up one tender, one contract for community delivery, which was won by the pharmacy network, and they work in shopping centres as well as their own pharmacies, and they go to local events such as health mealers. The second contract was workplaces and places of worship, and that tender was won by a private health company, and that works very well for us. They go into the large employers such as British Aerospace, Rolls-Royce. They come into our county council once a month, and it works well. We get good numbers out of that. Next slide, please. So, slide titled Lancashire HEA Planning. Yeah, the first and foremost, if you're going to do an HEA, decide why you want to do one. I'll admit we've done 2 now. And the first one, it seemed like a good thing to do, if I'm honest. The second one, so in terms of the first one, we looked at simply at equity of access, and it didn't tell us a great deal apart from that males underperform females. Second reason for doing one, on our second health equity audit, we looked more at outcomes. And again, I've been going around saying we're doing very well on numbers and invites, etc. But when anyone asked me the question, are you making a difference? I actually couldn't answer it. I didn't have any evidence of what difference it was making. Third reason for doing an audit is, and again, it works for me, is that when we recommission in a year's time, I'll have evidence to work up my specification and be more precise about future delivery. In terms of resources, we used a public health registrar, Louise Brennan. I have to say Louise did the vast majority of it. Took her a long time, but she did the vast majority of the audits, from number crunching, analysis, writing the report, and without her we wouldn't have done one, simple as. Timescales, always start, if you're going to do one in the current financial year, so if you're going to do one for 1920, you'd want to be starting and drawing down your data probably in early May, because data degrades very, very quickly. And clinical input, it's important. It's hard to get, but it's important, and it helps you work out why the stuff you're finding might be prevalent. Next slide, please. So HEA completing took us 7 to 8 months. I say us, Louise. For me, it's a 4-stage process. First of all, get the data. Now, the data is drawn off EMIS. It may not present in a format that works for an audit, so it needs cleansing, and it's an awful lot of data. As I said before, you need to get it soon after year end. For example, if a patient moves surgery, the data goes with them on EMIS. So if you've got a patient had a health check in March and they moved surgery in April or May, if you draw data in June, that data's gone. So it's quite important. And also, you've got a number of surgeries merging, certainly happening in our neck of the woods, which complicates the records. The following 2 slides, which I'll come to in a minute, will show befores and afters on the data. Initial findings, for me, I was aware that lifestyle referrals were probably suboptimal. I also managed the contract for all the lifestyles in Lancashire, and numbers referred direct from health checks were very, very low. In terms of research and analysis, that's stage 3 for me. Statin prescribing, anecdotally I was aware that health checks were sometimes a bit mechanical and going through the motions, so I want to look a bit more about that, and again it links to my previous comment about lifestyle referrals, so again I'll come to that in a short while. And finally, recommendations and conclusions. In a way, ours confirm my suspicions. and I'll be looking to use the findings from the HEA to future commissions, specifically around lifestyle referrals. Next slide, please. That says should be data received has gaps. Now, I'm sorry, it really looks hard to read on your screens. I've pulled it off one of our Excel spreadsheets that we got straight from EMIS, and that's about, don't know, about less than 0.1% of the total spreadsheet that you get. The actual number of columns are about 10 times that width, but it's just a snapshot so you can see. So on the left, you've got organisation name, then you've got patient identifier anonymised, age, gender, ethnicity, then indicator for the lower LSOA. And after that, a lot of gaps. So invitations, health check completed, etc. There should be numbers in those, but obviously on that part of the data there are gaps. Next slide, please. So after cleansing, so Louise spent honestly months on this, and she was able then to translate that data. Again, this is a small proportion, but it's just a quick indicator of the effectiveness of it. You can see on the left, I hope you can see anyway, the surgery names, patient identifier again, anonymised, age, gender, ethnicity. Then we've been able to translate the LSOA references into IMD status, so to get a picture of that. So it goes on through the report, so we're able then to draw a graph from it. Next slide, please. I'm now on Lancashire HEA findings title. So as I said before, first HEA didn't give us much information in terms of differences in IMD. We found the less deprived were more likely to attend, but there's no difference in invitations between IMDs. We found that older people were more likely to attend and white British most likely to attend. The second HEA, looking at outcomes, we were able to calculate the number of people that were diagnosed with conditions such as diabetes, hypertension, hypercholesterolemia and CHD as a result of their health check. We also discovered that 26% of high-risk patients from the health check were prescribed statins, which is higher than national, which should be is 19% nationally. We were also able to see that there were very low referrals to smoking cessation, alcohol, weight management, but we didn't know if that was simply that they weren't being referred or that the referral wasn't being coded. We couldn't tell from the data. Data recording, data input in surgeries was mixed, 12% of attendees missing data on smoking, 10% missing ethnicity, 38% missing alcohol consumption. So lots of gaps, which in turn we went to our clinical lead and said basically, well, why aren't they recording? The advice we got was that in a busy surgery with a lot of data to input onto EMIS from various sources, the data from health check is probably low on the list of priorities. So there we go. And finally, external delivered health checks, a lot of data missing. That was the biggest gaps we had. So when it was delivered outside of primary care, the input was quite suboptimal. Next slide, please. Our findings. So, stating what it says on the screen, good on offers, underperforming on referrals, high prescribing of statins, older males deprived areas most likely to prescribe statins. So if we go on to the next slide, which for me was quite useful, this is outcomes from health checks, statin prescriptions and referrals. It pulled the two areas together for me. If you look on the right-hand side, so you've got 1718, statins and referrals, and actual numbers at the bottom for the whole of the county. So, statins prescribed, bottom figure, 1,251, representing 3.6%. That is out of 35,000 patients who received a health check, 1,251 were prescribed statins. Weight management, 1.3% of those who were obese were referred. 2.3% referred to inactivity services, etc., etc. You can see across the line there. And this is going to obviously inform my thinking on the recommission next year. Point here is that NICE guidelines recommend all patients with a QRIS score of over 10% should be offered statins. However, advice about lifestyle modifications should be given before discussing statin use. So clearly something in Lancashire isn't quite happening there. Next slide, please. Challenges, HEA challenges. Time, as it says there, don't underestimate it. It's a big piece of work. Clinical input, you need to be quite specific about why you want it. Need the role to be defined and specific, but it can be helpful in advising you reasons why there are gaps in the data, as we discovered. And reacting to findings, a key challenge for me is making changes based on these findings, so I need to link it to recommendations for future commissions. And final slide from me, recommendations. With hindsight, I would now have a steering group, as Nikki said before, buy-in from sponsor from DPH, etc. No bad thing. It'll give you insights, oversight and leadership, and help implement changes from the findings. So I would definitely recommend that. Clinical input, as I've already said, yeah, very useful. Helps you to drive change. And finally, I will definitely be using the findings from this HEA to inform my recommission next year. And that's it from me. Thank you very much.
That's fantastic. Thank you very much, Alan. Lots of kind of practical tips and demonstrating the complexity and the challenges. It's brilliant that you've been the first local authority that we're aware of who's been able to look at equity of outcomes despite that being challenging. But I think it's also really interesting that this process can start to throw up and identify kind of quality assurance issues. So fantastic presentation. We will have questions. A number of them are coming in already, but we'll do them all together at the end. So we're going to move straight over to hear from Stephen about the experience in Oxfordshire.
Good morning, everyone. My name is Stephen Pennell from Oxfordshire County Council's Public Health Team, and the main aim of my presentation, which will be a bit shorter than Alan's, is to describe a little bit about the journey that Oxfordshire has been on and try and put a HEA in context of being part of a bigger picture or being part of a journey, rather than looking at it just in isolation or as a tick box exercise. So hope to provide you guys with a bit of an example of why we did a HEA in the first place, and obviously what an health equity audit has then ultimately led to. So, as many of you may know, I'm quite a strong advocate for the systems approach to raising standards and delivery of the health check programme, often known as STARS, and a lot of this information on STARS is available on the NHS Health Check website if you're not familiar with it. So this is basically bringing together some key criteria. There's 10 standards, and one of those standards is around equity. And obviously we did a process back in April 2017 with external and internal partners going through the STARS process. And what this did is the outcomes from this provided us a legitimate reason to actually undertake a HEA. Now, if you're looking at doing a HEA, one thing you may wish to do is take a step back and think about doing the STARS to see actually is a health equity audit a priority for you, or actually is there an area of the system that you're delivering in that may need addressing further or sooner, i.e. leadership. So one unique element, I guess, about when we then went on to do our health equity audit was that we had done previous equity audits, but only on a year snapshot cycle. So what we decided to do based on the outcomes from the STARS was to do a 5-year audit. Next slide, please. This is slide number 25. So I'm not going to go into great details of the findings or the method or etc. because our health equity audit is actually available again on the NHS Health Check website, and there is a link within the slide at the bottom there for you to find that. But in essence, the main finding from ours was that men aged 40 to 55 had the lowest uptake. And there was a recommendation in there for us to then go away, fully understand the reason why that is, and then to review our marketing strategy. There were several other recommendations, and again, you're welcome to look at those. I'm just going to pick those 2 key ones as an example. Next slide, please. Slide number 26. So based on the findings from our health equity audit, we decided we needed to understand the reasons why uptake in that age range was in males was low. So we decided to commission the behavioural insights team, who did a piece of qualitative work on our behalf with some local men. And what this did is it identified several steps and recommendations for some interventions that we could develop locally that would help encourage uptake of men aged 40 to 55 that live in Oxfordshire. Next slide, please, slide number 27. So this is then a bit of an example then about what we did with that finding. So one recommendation was to develop a male sensitive awareness campaign. And we did this, we chose this recommendation. Obviously, there were several recommendations. We had to do a bit of feasibility because some of those recommendations weren't within our scope, i.e. waiving cost or possibility. But one we did was around using our marketing approach. So back in late 2019, we ran this campaign. There's some examples there. I think there was about 10 or 12 mythbusters we used in the end. And the aim to address the male concerns about what the NHS health check was, and this is one of the findings we did from our behavioural insights work with those males aged 40 to 55 that actually they obviously had the concerns that around health check wasn't for them. So we're trying to debunk some of those myths using social media. Next slide, please. Slide number 28. So some of the key challenges, so some of these will be similar to Alan, I guess, but I guess this concept of time. So that STARS process we started was back in April 2017, and we've just run that social media campaign in November 2019. So you can see there's a 2.5 year process in terms of where we were and where we are. Obviously, some of that is down to kind of cost and also staffing. We've been very lucky in Oxfordshire to have access to some public health trainees or registrars. So they've supported us with a lot of this, particularly the health equity audit. Some of the challenges in terms of the health equity audit specifically, again, similar to Alan, is the quality and the detail of some of the data, particularly some missing data for those that did not attend their NHS health checks. There's also a little point to say that some of the findings from the health equity audit over the 5-year cycles did show perhaps some inequity, but there were very small numbers, so we had to be quite careful how we interpreted it, and we didn't invest a huge amount of resource and time and effort into that if actually the numbers were very, very small. Next slide, please, number 29. So finally, just a little bit about, okay, how can you learn from this? So again, a lot of the stuff that we've done is available online. Equally, my email address is available. So I'm very happy to take an email in advance for any of this information. But I think there is definitely something around having good contracts around your data management and collection. As a way of evaluating your services. So if you're in the process of procuring or contracting for some data management services, then I certainly really significantly look at that, particularly around retention periods and etc. So making sure you have access to some of this data if the contract ends, because it might be useful. Again, reviewing that actually, let's get the STARS framework embedded. Let's get some system leadership in place to actually make sure that this is something that's a priority. We talked a little bit at the start there that is it worth doing a 5-year or a 1 year? Now, actually, the 5-year audit that we did had similar outcomes to the 1 year. I guess the difference here is actually when we start looking at the 5-year, the numbers are a lot significantly greater, so we can start making a little bit more cause and effect. And also just, I guess, to kind of think a bit about it not being a tick box exercise, which often we can do in our roles. And actually it's important when you're doing this process to say, okay, so what? So if you do a health equity audit, what's it going to lead to? What changes are you going to make to your local programme? So there's going to be some types of questions at the end. So for now, I'll stop my part and move on to the next presentation. Many thanks.
Fantastic. Thank you very much, Stephen. I think it's really useful how you started that, thinking about the STARS framework as a way to think about, although NHEA can be the right and a useful thing to do, it's about looking in the broader context of the programme, because it's not necessarily always the first priority. That's really helpful. It's fantastic. I always like to ask the so what question. And, you know, what's the point of this in terms of what you're going to do as a result of the HEA? And it's really nice, that kind of example you've got, for example, of the myth busting, that what you did to actually get to those males 40 to 55 so that they're able to increase their access to services. That's great. But also the practicalities, as you say, things like the kind of data management and extraction stuff. So really helpful stuff. We are now going to move on to input from Hampshire County Council. Unfortunately, because we had to change the date, Fatima was unable to join us. So I am going to present on their behalf. So Ellen just moves on to the correct slide, which is number 32. So The input from Hampshire is less about the health equity audit process itself, but it picks up on, as Stephen was just saying, the kind of so what factor. They undertook a health equity audit in Hampshire to inform the improvement strategy to ensure the effectiveness of the programme. And the key finding they found is that there was inequity in the access identified, particularly for males, smokers, people who were obese, inactive, those from deprived areas and BME groups. So real quite significant inequality in access to the programs, and also poor take up from those who are higher risk, and not systematically identifying those with raised hypertension, cholesterol, and CVD risk. So if we go on to the next slide, in terms of how they then applied those findings, they undertook an HEA and used the findings to move to an approach that targets allocation of resources to those at risk within universal programs. And it's really important to make that distinction between moving to a targeted program, which would go against the regulations, which is for a universal program, and targeted allocation of resources within programs. And that's what health equity audits are critical for, putting the resources into the right place, because clearly you do run the risk if you don't look at inequity in a thorough way of increasing inequity. What they then did after they'd done their HEA and they'd found those groups who weren't accessing the program so effectively, even though they needed to be based on their kind of CVD risk, they piloted a range of behavioural insights to understand what would improve take up for those particular target groups. And then they used those to inform their service specification to incentivise practices to provide checks to those groups that the HEA identified as being underrepresented. And they then obviously kind of monitored that to understand the impact that was having on take up from those groups currently underrepresented. And it's early days. They've only done this from it's the first year that they've been doing it. We're not even through the first year, so it's early days, but the findings do seem to be positive in terms of making the take up from those groups is very much increasing. The challenges, moving on to the next slide, so we are on slide 34. Time taken to do HEAs, it's something that people often say, you know, if you've got a registrar, it can be a great project for them to do. But doing the HEA, but also the piloting, agreeing and getting sign up to new service specifications, which always seems to take longer than people expect, and building it, then the practicalities of building that into the GP clinical systems and templates that they were using. In terms of insights and learning, they did feel it provided that robust evidence to inform decisions about resource allocation, you know, which can be challenged and it can be tricky, but that's what they used it for, and they've got that data to kind of demonstrate why they made those decisions. And it's also obviously providing a useful baseline so they can very clearly see, if they do an HCA in, you know, a year's time, what difference those changes have made. But of course, and this links back to a point Stephen made earlier, that's only going to work if you ensure you've got those kind of reporting requirements and your data sharing and your protocols built into the specs and the system, so you can actually get out the data that you need. So we're going to move over now to Kent to hear from Tom.
Good morning, thank you, Nikki. So yes, my name's Tom. If we could go back one slide, if that's okay. So my name's Tom Boyle. I'm an intelligence manager at Kent Public Health Observatory. We're a team of 8 quantitative analysts. We're very much intelligence analysts, not medics or commissioners, and centred in the southeast of England. And we're sharing the results of our recent equity audit, which for those interested in methods, it's technically a blend of an equity audit and a loss to follow-up study. So next slide, please. If I could start by taking us back 3 years when a colleague ran an equity audit of access to the health check programme, and that's the graph on the right hand side there, which it may be difficult to view, but it broadly shows that those who are more affluent are more likely to take up their health check offer. So affluent achievers in this segmentation are more likely to take up their health check offer than those who are classified as urban adverse. This work builds on that first phase of audit and now focuses in on those who attended their health check offer, were found to be CVD symptomatic, and then we look at how their treatment and their prevention varies by the equity group that they find themselves in over the course of at least 1 year. So we looked at people who were invited to their health check in 2017-18, and we tracked them to the end of 2018-19. And perhaps I'll say something about attribution of that health check later on in the questions and answers. And we particularly focused on those with hypertension, and we found that they were voluminous enough to look at subgroup analysis, so we've honed in on those. And just a tiny bit more on scope before we go into findings. So we're incredibly fortunate in Kent to have access to a linked database, whole population pseudonymized database, the Kent Integrated Dataset, that allowed the work, and we were able to have direct access into the data. And within that data, we have 90% of general practices from Kent flowing in, so a rich amount of data. Next slide, please. So we were able to look at diagnosis, treatment, and outcomes within our audit. It's a 30 to 40 page report, so we're having to distill quite heavily within this presentation. But first of all, we looked at diagnosis, which is the table in the top right. And we were able to find just over 1,000 cases of hypertension from this 1 year cohort, 251 of type 2 diabetes, 66 chronic kidney disease. And then we were able to benchmark those figures against a prominent national evaluation by Robson et al. In 2016. And we saw about 80% of the expected cases. If you were to apply the national rate to Kent and it worked perfectly, we were getting about 80% of cases, which warrants a bit more investigation. Moving on to treatment, we were able to look at the rate of detection and medication for people with hypertension, so medication with antihypertensives, and we found inequality across CCG area, gender, age and deprivation. Here we just show CCG area, and you'll see in the graph on the bottom right, South Kent Coast CCG, one of our CCGs, was statistically significantly higher than the rest. It's also the area with the highest rate of modelled undiagnosed hypertension, so there may be good reason why that CCG area came out higher. Next slide, please. So then we were able to look at outcomes for people who were diagnosed with hypertension, and we found that just over 3/4 of these medicated hypertensive patients who had follow-up blood pressure records had one systolic blood pressure record under 140 and one diastolic under 90 within a year of their health check, which is why we're mentioning those specific figures. That's the threshold for high blood pressure. So a really positive finding that the majority were able to reduce back under the threshold within a year. And lastly, in terms of findings, we were able to look at lifestyle pathways and behaviour. The health check's also an opportunity to identify, manage and reduce risky behaviours. This one is physical inactivity. We found that if we follow that pathway diagram, we found just over 10,000 inactive or moderately inactive patients from our 35,000. Only 6 in 10 of those were offered, or recorded as being offered lifestyle support. So potentially a missed opportunity there for 40% of those people. That's the last one on the findings. So just general reflections on my final slide. Starting with key challenges, the most difficult thing on this was getting sufficient patient numbers to do subpopulation analysis. We were only able to do that for those with hypertension. Had we have combined multiple years of patients, we may have been able to do more, but we just looked at 1 year here. I've seen from the questions that have come through on the webinar, people are interested in attribution. Definitely an issue for us. So we used a 1 year time window, a minimum of 1 year time window. Anything longer than that, we found it difficult to attribute back to the health check. GP coding, the vagaries of GP data were very difficult. There were patients who seemed to be ineligible, and we had to do a lot of data cleansing and cleaning. And then within our Kent Integrated Dataset and the health check specific part of that, there's an enormous amount of data that we could have looked at. So managing the scope of the possible analyses and all the pathways was difficult, but we managed it in the end. The positives, so I think the big one for me was moving the conversation, or just as others have said previously, moving the conversation from access to the health check programme into efficiency and effectiveness, so the outcomes of the programme, and taking commissioners into a different stage of scrutiny. And that's it from me. Thank you.
That's fantastic. Thank you very much, Tom. I've been quite close to both phase 1 and phase 2 of the HCAs in Kent. Kent were involved with piloting the guidance, and I think that kind of ACON segmentation is really interesting. I've not seen others do that in health equity audits, but it's a really interesting dimension that adds a lot to the process. And again, it's fantastic to actually be able to look at outcomes, despite the fact it's been incredibly challenging, and there have been issues around data, but it's a real achievement. So thank you, Tom, and thank you to Stephen and to Fatima for her input, and of course to Alan. I think that's been fascinating insight into how HEAs really can help you use your limited resources to make sure a universal programme can work for your local populations.